Thank you all so much. This is Jessica Marsh with me, and we are thrilled to be here. We're thrilled to have you guys here today. This is a topic near and dear to my heart. I actually lost my hospice foster cat on Friday, so a little high on the barometer. Sausage came to Austin Pets Alive from our rescue partner at Austin Animal Center. She presented with a 90-degree head tilt, which is pretty awesome when you think about it. You got the cat going like that. Unsure symptoms. The owner surrendered. She was owner surrendered, and the owners had done several diagnostics. The vet was unable to determine what was causing the problem based on the diagnostics, and the information we got was that the animal was just surrendered. As is standard in Austin, what we call the last 2% cats with challenging medical behavioral issues come to Austin Pets Alive whenever possible so that we can do a final assessment and see if there's anything there to work with. Sausage came to me after about 10 days of work in the house. We did determine that she was in her end stage of illness. She spent the last week not getting poked, prodded with sharp things. We watched Cubs baseball. She hung on through the end to watch the World Series and watch the Cubs win it in 7. Go Cubs. And on Friday, she passed away in my lap after having demanded that every time I put her down, I needed to pick her back up again. That's hospice in a nutshell. Quality hospice program isn't just about the end of life, it's about beginnings in your program, because the things you learn here are going to permeate everything that you do in your organization. With that, I'm going to turn it over to Jessica, and we will take you through the journey.
Good afternoon, everyone. Like Clara said, my name is Jessica Marsh, and I am one of the senior hospice volunteers with Austin Pets Alive. So let's start with some terminology. We call it FOSPICE. And what is FOSPICE? It's fostering plus hospice care. Differentiating because it's not hospice care for humans, but it's also not just fostering. We're above and beyond just a foster home. We're really taking an animal in and giving it that dignified end of life that it deserves and that you would want for your own pets. So we call it hospice care. And here's a little bit of an overview where we're going to be going. And at Austin Pets Alive, we believe that every single cat and dog that comes into our program deserves the chance to be a beloved pet. Whether that be an animal that's going to be adopted and have a nice long 10, 15-year history with a family, or an animal that we know only has a little bit of time left, they still deserve that chance to have that dignified ending as a beloved pet in your home or a loving euthanasia at your vet's office. In FOSPICE, that's one way that we do help to save that last 10%. Once we reach that no-kill barrier where we're saving 90% of animals, a good portion of that last 10% are those dogs and cats that have very serious illnesses from which they will not recover, but that they could live a decent life right now. And that FOSPICE care is how we help to save part of that last 10%. You heard Clara mention the last 2% on cats in Austin right now. We are on that last 2% of cats. And overall, we're on that last 4% total dogs and cats. We're at about a 96% rate on average right now. So some definitions. I'll let Clara take it away with this one. She's better than I am with this one. The medical definition of hospice. What do we mean when we say hospice care?
And what we're looking at with hospice care is a definitive medical diagnosis whenever possible. It can be cancer, it can be end-stage kidney failure, whatever it is, something with a definitive medical diagnosis and an active decline. Now, there's two ways of looking at hospice. There's also kind of a broad category of this is an old animal, maybe a senior who's got a chronic medical issue. But for real hospice, you want to try to make that definition active declining medical condition as well, because there's differences in how you're going to treat that. Acute versus chronic illness. Acute means something that's happening currently and rapidly versus chronic. And again, you can have cats and dogs in renal failure for 5 years. You can have long-term illnesses that are terminal, but they're not terminal right now. And you want to make the distinction between this animal is going now versus this animal maybe has another 18 months. Disease and type of progression is going to impact that. Medical mystery versus hospice. You open the box from your adoption partner, and what you thought you were getting is not what you're actually getting. You don't know what's wrong with this animal. Some people's decision is to say, oh, it's sick, I don't know what's wrong, it's going to die. That's not always the case. There are weird medical things that look like they may kill an animal, but may not. Using sausage again as an example, one of the things our vets were leaning towards diagnostically is toxoplasmosis, which can present with similar symptoms to what she had. Medical mystery cats and dogs, you need to treat. You need to poke and prod. You need to see what their potential is. Those animals can recover. They go home with people. Out of personal experience, 60% of the medical hospice fosters I have taken in, they actually didn't die. They went home with somebody, and they're living long, happy lives. So keep that in mind. There's a line, not everybody stays the same, which takes us into major medical fostering. Major medical fostering is cat been hit by a car. That's not hospice. The animal may die, but it's not the same as hospice. So
it's intensive, often short-term, but intensive care to get that animal
Correct.
back to an adoptable quality.
The big thing here, and the thing we want to emphasize, is quality of life. Quality of life is important throughout your organization, and looking at quality of life goes back up through every type of animal you take in with complicated medical issues.
So what are your tools when you are working with hospice? First thing you need those foster homes. They're going to provide the care and comfort to that dying dog and cat, and it's going to be in a home environment where it's less stressful, and the animal's going to be more comfortable. They're going to be happier out of a kennel, out of a loud medical clinic or hospital environment. At the same time, that foster home helps you as a decision maker and an organization to be able to monitor the quality of life of the animal and keep your medical staff apprised of what's going on and when it may be time to start having those end-of-life discussions. Of course, you're going to need some basic medical supplies. I think Clara and I have joked that between the two of us, we probably could run a pretty good MASH unit out of our bathrooms. So whatever issue is going on, if there is a zombie apocalypse, go to your medical foster's house because you will be set for life. So we've got basic things: wound care, a nebulizer, pill cutters, because you're going to probably be giving a bunch of medication if you've got a medical or hospice foster. Pill crusher for with those ones that are either tricky to pill, or maybe a cat that's got a lot of stomatitis and doesn't do well with chewing things. You can crush the pill up and give it in a liquid. Supplies for force feeding. As we all know, a cat that stops eating is a cat that dies. So being able to force feed a cat to get it over that hump and back to eating well, you need to have those supplies on hand. And then, depending, of course, on the legal situation in your state and what your vets in your program are comfortable with, commonly used medications.
The other thing about medical supplies for your fosters, if you are in a position to make sure that they have adequate medical supplies or encourage them to purchase them, that means your vet is not getting a phone call at 2 o'clock in the morning saying there's green pus oozing off of my cat or dog, what do I do now? This helps reduce your workload when you can encourage a certain level of self-sufficiency in these fosters. They will still contact your medical control team appropriately, but self-sufficiency gets everybody through the evening into the morning. Nobody wants to be up at 2 o'clock in the morning with a panicked foster on the phone.
Yeah, and some of these basic supplies, like a nebulizer or the force-feeding supplies, that can help you keep it from becoming such a big emergency. If you can start nebulizing tonight when that cat's really congested, maybe it's not going to become that emergency where you're calling your vet at 4 o'clock in the morning and saying, hey, Dr. Bars, I'm going to need you to come to the shelter because this cat can't breathe. So mentors. We use a mentoring system and would highly recommend that other programs do the same. It's an opportunity for you to use your more senior volunteers to help recruit new volunteers and to help get those volunteers to stay on so that they in turn can recruit additional volunteers. And over time, your hospice fostering program goes from maybe 1 home, 2 homes, to 6, to 10, to 12, or 20 homes. Your mentor can help in acting as a liaison between the foster and the clinic. A lot of the times the mentors have a little bit more medical information and medical knowledge than the other foster homes. So they have a more broad knowledge where they can speak to the medical team and really break it then down to the foster and explain what's going on. They can enhance foster retention. I know as a hospice foster, if I'm having a really bad day and I'm not sure what to do next with the dog that's in my house, and I don't know if it's time to make that decision for him to be euthanized, and I don't know where I'm going, it helps a lot to have another mentor that I can call and say, what do you think? Have you seen this before? What's going on? And again, help prevent burning out your foster homes. No one's going to pretend that hospice is easy. It's hard work. It's difficult for all of us, but when the mentoring works well and you've got that great relationship where you have someone to support you through it, you're less likely to burn out at foster home and more likely to get them to say yes next time.
One of the key things that generates burnout in medical, hospice, anywhere in your organization is fear and uncertainty. Quality mentoring along with quality processes reduces that fear and uncertainty. When people aren't scared, they make better decisions, they feel more in control, they feel better and are in control, they will stay with you.
So quality of life scale, this is huge. I'm going to let Clara cover this one because she does it so well.
Quality of life scale, there's a great one online. We're going to provide it to you on the back end because I didn't get approval from the vet who originated it to use it on a presentation. You can find them online. This is an empirical, measurable tool that you guys can use to help make decisions. It's a numeric scale. It runs through, depending on which one you're looking at, 7 to 10 categories of quality. It includes things like, is the animal staying clean? Can the animal feed itself? Is the animal hydrated? What are the pain levels? Does the animal appear to be having a good quality of life experience? Each category gets a number from 1 to 10. If you don't know what the number is, make it a 5. You go through your categories. At the end of the list, you have a numeric range. Under, say, 30% is considered a point where you want to talk with your DVMs, other staff, about making a euthanasia decision. Over that, maybe you're not making the decision. There's no magic number out there that says when your cat or dog is at 5, that's when you have to euthanize. What you're doing is building data that you can refer back to, and so that everybody's on the same page. We've all got that foster in our program who is going to ride an animal to the very end of the line, even when like all 4 limbs are off and everything's coming out of them because they're so desperate to save them. The vet sees one thing, the foster manager sees another thing, the foster sees something else. By using a numeric scale, everybody has to pull to the same center and get an idea of what's going on. And again, it's a tool that can be used everywhere. You can use it for animals in your medical clinic who may be approaching end-stage illnesses. You can use it for dogs in behavior programs. It's not the be-all and end-all, but these are tools to help you make decisions in an informed capacity so everybody's on the same page. One of the biggest knocks against no-kill consistently is quality of life-related issues. People talk about no-kill shelters being hoarding situations. Using a good quality of life scale can prevent that from becoming a problem. Everybody's got to be on the same page. This is one way to do it.
And like we said, that you can permeate your entire program. So you have a dog maybe that's got really high kennel stress. You can evaluate his quality of life and determine what can we do to enrich this dog's life and bump that number up, make him a little happier. And that's not involved in a discussion of euthanasia for that dog, but it's extra enrichment, additional exercise, training. Is this an animal that would benefit from being in foster home instead of in a kennel? Your whole program can use quality of life as a holistic view of what is best for that individual animal. Of course, communication, cooperation, very important in all aspects of life, but especially important when you've got fosters that are entrusted to take care of your end-stage animals. So being able to communicate easily is very important. Email, text message, phone calls. Make sure that your hospice fosters and the mentors have each other's contact information that they can get in touch with each other very, very easily. And of course, work to develop those relationships between your medical clinic, or if you use a private vet for your services, depending on what your program looks like, between those vets and medical professionals and your fosters and the mentor. And a lot of times the mentor can help to introduce that foster to the medical team and work on that relationship building. Something that we have is we always have an on-call technician that all fosters have access to, but the foster mentors have direct access to the veterinarians overnight if there is a true emergency situation. And we also have definition of what a true emergency is. Because for some people, oh, my dog ate a bunch of grass and threw up is an emergency. But that's not really something we need to call and wake the vet up at 4 o'clock in the morning for. This is, I cannot breathe, I cannot stand up, I'm having a prolonged seizure. And we also have a closed Facebook group for our APA hospice and major medical fosters, which helps in building a sense of community. It gives us a place where we can talk to each other privately, share our stories, support each other, and just get communication, bounce ideas off of each other. I think it's been a really great group. We've had it going for about 6 months now, and in that time period, I think it's been a lot easier for hospice fosters.
And when you're working on your communication element, please remember that you need to make sure your communication spaces are safe spaces. Hospice and medical fostering is scary. People are going to get angry and upset, and that's a normal part of grieving processes for folks. Don't create a dynamic where people can't talk about being angry, upset, hurt, mad at your vets, mad at the program. That's a safety valve, and it's also a good way for you to be able to keep an eye on what's going on. If you don't know your fosters are stressed and upset, you can't fix anything. If you can't fix anything, you lose fosters. Fosters are not an infinite resource, and quality fosters are really not an infinite resource. We want to protect them and cherish them.
So here's an overview of our process, and we're going to go through each step. But it basically starts intake and evaluation, going to foster, communication, and ongoing evaluation, along with routine medical appointments. That's a cycle that happens over and over, all the way to the end of life decision, and we'll go through each step individually. So medical intake and evaluation. An animal comes to us from one of our rescue partners, and he receives a full medical evaluation. We assess a quality of life score at that time, so we know what our baseline is. And we also start to develop a treatment plan. Now, sometimes we don't know all of the animal's issues yet, but we can at least develop a plan for the most apparent issues and that which is most urgent, making sure that that animal is not in pain and that they are getting their most urgent needs met. From there, the ideal task would be to have the medical clinic alert the foster mentor so that they know there is a new hospice foster coming into the program. Basic information: name of animal, name of the foster, contact information if it's a newer foster, initial quality of life score, and just basic medical details of the foster. It could be, okay, here is Stardust. She is a 12-year-old female domestic short-haired cat. She is in end-stage renal failure, and she's going to foster with Natasha. From there, the animal transfers to foster. That's my foster on the photo. I just had to put him up there. So the medical clinic sends the foster and the animal home with the initial quality of life score. And this is the big one: an explanation of the medical condition, planned course of treatment, and what changes can be expected. Excuse me. Sometimes the changes that you see with a hospice patient can be scary if you don't know what to expect. If you have a mass that may ulcerate and the foster doesn't know that that's going to be happening, that would be terrifying for a new foster. But if at the front end we can say, we expect this disease will progress to X, and you will probably see Y and Z, and we can tell the foster that up front, they'll be a lot more informed and much more likely to do this again with us. And of course, the necessary medications, and importantly, how to administer those medications and treatments. I'll let Clara pick up this one.
Your first couple of days as the mentor, you want to make sure you get a hold of the new foster quickly. Hi, I'm your foster mentor. I will be walking you through this nice, scary process. Let's make this not as scary. Verify that the animal is still alive and breathing, and then ensure that they have a hard copy of whatever quality of life scale that you determine that you're going to use. Walk them through the process. Again, you're doing broad overview. You're not necessarily going to know every end outcome. Go with your general. You want to make sure that once they get home that they do a quality of life score so that you know what they think they're seeing, and you can kind of start, again, finding that middle ground on everything. Are they eating? Are they drinking? Everything going on? Great. Have at it. Have fun with your foster. Check in with them on a regular basis, but remember, sometimes hospice isn't always hospice, and sometimes hospice is fast, sometimes it's slow. Check in at least once a week, but don't harass the foster incessantly. Give them some breathing space. Keep an eye on quality of life. Listen for things that sound like there's a medical deterioration of what's going on. Continue to interact with the foster and walk them through what's going to happen. Is your animal in pain? How are these things going to work? Do this early, because the last thing you want to do is have this conversation 2 days before you're facing a euthanasia decision. Continue to monitor for deterioration. Hospice has to have deterioration. If there's no deterioration, this isn't a hospice cat right now. It's an old sick thing, but it's not hospice. The question I coach everybody with is, what's next? If you're always asking what's next when you're looking at medical treatment and options, that helps to start clarifying things a lot. A cat who's cruising along great on subcutaneous fluids and then develops an upper respiratory infection, well, if I treat this, what's next? Well, then the cat goes back to having a good quality of life and cruising along on fluids. Oh, okay. Versus the cat who's down to 3 pounds, struggles when you give fluids, stops eating, and has an upper respiratory infection. Well, what's next? Well, this cat's progressing to end-stage illness. I have to do 2 weeks of poking and prodding on upper respiratory infection protocol. I'm not doing that. That was the determination that happened with Sausage, is she was force-fed for 2 weeks because she was having trouble eating. She hated it, and she kept throwing up the food. The discussion between myself and the medical clinic was, she's throwing up the food, she's not tolerating the medication, and she's fighting me constantly. Based on her condition, this is not acceptable to do to this cat. And that's part of how the decision-making process moved to the next step, which is no poking and prodding, very minimal palliative care, and letting them finish out their quality of life. Again, mentoring is so important because sometimes your medical staff can disconnect from what your foster in the home is seeing. A mentor can bring things back to center by interpreting medical things for them, and sometimes the mentor has to be able to go into the clinic and say, no, I understand what you guys are saying, but this is what's actually happening in the home, this is what we have to address. Be the bridge.
And then the hardest part, end-of-life decisions. It's important that you establish a protocol ahead of time for determining what is the appropriate time for euthanasia. You want to incorporate that input from the foster, who really knows the animal best, from the mentor, who's been there for the entire process, and from your medical clinic. And of course, you always want to take into account the animal as an individual. For example, maybe you have a dog that is a hospice medical patient, but also has severe behavior problems. That's a dog you might not be able to give fluids to or to force feed, so you might make an end-of-life decision sooner for that dog than you would for a dog that's very easy to force feed or give fluids to. Feral cats is the same thing. The more you have to handle them, force feed them, touch them, you're going to stress them out more and their quality of life further declines. So you may make a sooner euthanasia decision. And finally, cognitive dysfunction is one that we've been seeing a lot with older dogs, where maybe physically they're okay, but mentally they are confused and scared all the time.
No kill doesn't mean that we don't euthanize. No kill means that healthy and treatable animals are not euthanized. And within your hospice program, for a long period of time, these animals remain treatable. Please keep that in mind. Euthanasia decisions must be made. They must be made in a compassionate manner for the animal, for your foster, and for your community. But you're not going to just skip out on this. This isn't we're going to wait. It will vary depending on the patient. Most of my fosters have passed with veterinary euthanasia at our medical clinic. Sausage deteriorated rapidly from Thursday night into Friday morning. She was unable to get up and lift her head. She had urinated all over herself. Her breathing was starting to get shallower. Based on past experience, it was very clear to me that she was going to pass fairly soon during the course of the day. I contacted the medical clinic, and based on my experience, I felt it was inappropriate to take this cat who had been through so much stress in the last 6 weeks in the car to the medical clinic for more poking and prodding, more importantly, potentially a frightening car ride that's going to kill her. I didn't need that. She didn't need that. She was not in distress. Her body was just progressively shutting down, and we made the decision to go ahead and allow her to pass at home. She was able to pass away in my lap, which for me as the foster was great. I don't get that moment very often. That doesn't tend to happen with cats. And it was good for her. So it's good for everybody organization-wide.
And so the mentor's role in end of life is to reduce stress for the foster, for the clinic, for the animal, and in turn make it more likely that that foster will take on another hospice case in the future. If you've been there for them and you've helped to pave the road and make it a little bit of an easier time, even though it's still hard and it's still scary and sad, if you made it just a little bit easier through great mentoring, you can probably get them to take home the next cat or dog too. So to that end, when it's nearing time for end-of-life decisions, you need to be touching base with that foster more regularly, especially if it's a newer foster. Make sure they understand the euthanasia process. You don't want a hospice foster who's been loving this cat in their home for 4 or 6 weeks to go to the appointment having never been present for euthanasia before and not know what to expect. Whenever possible, we like to be present with the foster to provide additional support. Always follow up with the foster after the euthanasia. Make sure they're doing okay, whether there's any additional support or resources that they need, and keep just checking in with them.
One point just to throw out for everybody so you put it in your organizational box. Most rescue groups have developed a partnership for disposal of animal remains. Frequently, those partnerships do offer cremation services. That can be a really important thing for your fosters, being able to get the animal cremated and come back because they bond with these animals and they want them to be able to come back. If that's something within your resource pool that's available, talk to the vets you work with, outside partners. Austin's a great place. We've got like 6 different groups that will do cremation services. Pet Loss Center here in Austin is currently doing ours. This makes a big difference for people.
Okay, so there are also other outcomes. Like we talked about, there are unexpected recoveries and adoptions. Both of the animals pictured here, Ethel down in the bottom corner and Stardust in the top corner, were supposed to be hospice fosters. But they actually both were adopted and Ethel got 9 months in a loving home. Stardust is still running around and playing to this day. Of course, though, with those adoptions, you want to make sure that your adopter is on the same page and knows exactly what's been going on with that animal. So we do a full disclosure of all medical records and actually require that the potential adopter meet with our veterinary staff to discuss those issues and make sure they understand what they're taking on. So a few case studies we wanted to go over. I'll do the one that was my foster first, if that's okay. Pepper here in the middle, he was actually my first hospice foster, and Pepper was what you would think of as a very traditional hospice case. He came to the shelter from one of our rescue partners, was a 4-pound Chihuahua full of sass. He didn't really enjoy taking his medication, but he was in end-stage heart failure, so he really needed that medicine. He ended up at my house because I could get his pills down without getting bitten. And we had Pepper for about 2 weeks. And throughout that time, his condition deteriorated some. So we worked with the veterinary staff and made the decision when it was time to euthanize him. And his ashes are on a table in my living room to this day, and he got us started at hospice fostering, and we've not stopped since.
So the two cats are actually a good example of acute versus chronic hospice. Agatha was a blind and deaf cat who came into our city shelter system and then came to Austin Pets Alive as part of our last 2% of cats. She had chronic end-stage renal failure, and because of being blind and deaf, which is challenging for a cat, she would frequently shut down in most of the environments she was in and presented with low quality of life. She kept kind of dribbling along. I got contacted to do an eval on her, brought her into my house, and working on some of the strategies that we have for dealing with deaf and blind animals, we were able to get her quality of life to elevate fairly rapidly. After 3 weeks of evaluation, she was passed off to another hospice foster, one of my repeats actually, and she got another 6 weeks and was euthanized for kitty cat dementia and confusion coming along with it. Pinta, on the other hand, came to us from a member of the community. She was found in the streets being fed French fries and poked and prodded by people unkindly, and very kind member of the community just rescued her, brought her to us. She had squamous cell carcinoma, which presents as large lesions all over the body, and at the point in time where we got her, she had 4 large masses. The most problematic was in her mouth and jaw, progressively impacting her ability to eat and breathe. We did an evaluation on her. She was in active decline, but had no intention of being dead just yet. So we elected to have a fabulous week, and Pinta got a party every single day. We had Pinta's bucket list. I got a bunch of people to chip in ideas for what we did, and Pinta had breakfast tacos and ice cream, and had her birthday party. She had Christmas. It was fun. It was a great way to engage the volunteers in the fun process of it, teach them that this wasn't scary. And Pinta is a cat who was euthanized before she was ready to be done. However, the mass in her mouth was reaching a point where it was going to rupture, and I didn't need her to rupture that mass in her mouth in my home. But she had a delightful week. The fostering community really enjoyed having her as part of our participation process. Then we have the Hospice Cats, who turned into major medical and then wandered off and got themselves adopted.
Stardust is the one that we showed you on the previous slide. Stardust came to APA, expected to be hospice, not expected to be with us for more than a couple of days. Her foster, Natasha, took her home thinking, I'm just going to give this cat a great weekend. She was in end-stage renal failure. She was severely emaciated. I don't think she even weighed 3 pounds. She could barely move, barely lift her head.
Wicked diarrhea.
Horrible diarrhea. Natasha had her for 6 months, steadily improved over that time. Turns out she does still have renal failure, but it's chronic renal failure, and she can live with that for a while. She was diagnosed with irritable bowel disease and with special food, now weighs over 8 pounds, is happily adopted, and is romping around with her new cat brothers and sisters in a very happy life. She's a wonderful success story. And then Medical Mysteries turned into hospice. These two both came through my house. Kirk is what we thought was a rat terrier mix. And he was about 14 or 15 years old, but he had the hugest distended abdomen. If he was not male, we would have thought he was pregnant. And we couldn't figure out what was going on with him. Ultrasounds, it didn't really look like a mass, but we just kept treating him as best we could. And he turned hospice ultimately when he no longer was comfortable and wasn't able to eat anymore. We did find out after he passed, he had a 6-pound mass. His body weight before the mass was removed was 13 pounds. So the mass was about half of his body weight, taking up his entire abdomen. But he had a great, 3 months, I think? 3 months with us. And he had a great time during that time. He was just one of our dogs and loved to run and play. And Sherlock was another one. He came into APA. He was a 17-year-old dachshund with Demodex mange, Cushing's, multiple ulcerated masses all over his body, the worst teeth I have seen or smelled in my life, and kind of a bad attitude. And we took him home for the night to assess him. He stayed with us for 4 months. And his masses were a major problem, but over time he actually became hospice because of his cognitive dysfunction. When he got to the point where he was so confused that unless one of us was actively holding him on the shoulder, he was screaming in fear, that's when we knew it was time to let him go. But in typical dachshund form, we were giving him some snacks before his euthanasia, and he attempted to kill himself by scarfing a whole Oreo at once. So he went out laughing at all of us, but had a great 5 months with us. And more than any hospice animal ever has been, that's the one that was very much our dog. Okay, so the tips for starting a program. Here are kind of what you need to do. First, recruiting your volunteers and your fosters. Look within your existing base. You've probably already got people who want to foster, but maybe they don't have time to go to all these adoption events, or they just need a short-term commitment, or maybe they have interest in medical fields. Maybe they're nurses or doctors themselves, or they already volunteer with your medical clinic. Recruit them. Get them to take home a medical case just once, just to try it out. They'll probably get addicted and keep doing it. Find your mentors from within your existing set of mentors. It could be people that have just been fostering for a long time, maybe people that are fosters that also are employees of your program, and so they know a lot about how the program works, or they're fosters that also volunteer in your medical clinic, so they know a lot about how the medical side works. And of course, there are always going to be those special categories, so you might need to develop some specialized hospice programs for end-stage FELV, pan-Luc, when it looks like it's not going to get better, distemper, parvo, FIP, and to decide whether you want to separate your major medical and your hospice programs or have them as one. Ours are pretty well blended. We've got some fosters that will only do one or the other, but most of the fosters that will do a hospice will also do major medical, and then everyone's kind of got their varying degrees of major medical. Can this foster do IV injections at home? Or can they do sub-Q injections at home? Or just liquid medication for them? Just decide where each person's skill set is so that you can determine what the best type of animal for them would be. And of course, when you're developing your hospice program, you have to decide end-of-life decisions. Who has decision-making authority? Can the foster make the decision on their own and say, "Doc, this dog is done. I'm sorry, he's done. He does not want to do this anymore. It's time." Or does the medical team get to make the decision? And you have to also develop a procedure where, what if the medical team and the foster aren't agreeing? We would recommend discussing it with a third party, like a program manager, either your dog foster program manager, or your dog adoption program manager, your cat adoption program manager, your cat foster program manager. And can you also develop standard criteria that you use in every single case? What are the hard limits? One hard limit we kind of have is if you can't swallow, it's a pretty good idea that it's time. But there may be different circumstances. So of course, always remember that every animal is an individual. So maybe this animal is going to have a few really bad days, but maybe that'll lead to some better days.
We're going to hit, towards the end of it, we're going to pull back to Sausage, who's the cat who starts us off today. So 2:30 in the afternoon, she passed away. I had to work. I had to go out and try to adopt cats out tonight. The wonderful folks of Austin, so I tootled off to my adoption shift and was doing okay. I'd had my plan, worked with our plan, in a good place. About 5:30, I get a text from another adoption counselor, and she says, "So, hey, Sausage's people are at this adoption location." I kind of blinked at the phone and I said, "Okay," and she replied back that, "Yeah, actually, they're really nice people." So it turns out what happened was they had gone through the diagnostic process with a local veterinary doc in a box. The vet was unable to determine what was going on and recommended either euthanasia or surrendering the animal to the shelter as a chance for anything to happen. After what had been done diagnostically, they didn't have resources to make the euthanasia decision. So they elected to surrender her to the city shelter and were assuming that she had died. They didn't know she was still alive. They didn't realize until that moment where my coworker explained that she had passed that day. And they broke down in tears, and I broke down in tears at the other location because of all the things to happen that day for those people to walk into our adoption center. They came back yesterday, and after following our appropriate adoption counseling process, they adopted a new cat from us and took her home yesterday. What I want you to remember about all of this, everything you're learning today, no kill isn't just about taking care of these animals, it's about taking care of our communities. You guys are contributing to building stronger, healthier communities. Do not forget that. Hospice is not the end of your programming system, it's your beginning. We thank you so very much for coming. Thank you to Maddie's Fund, and thank you to Best Friends for helping host us. And now we're going to go ahead and turn everything over to questions. Jessica, Marsh, and I both thank you so much.
Thank you.